呃，各位
那个帮我
各位会员，1点40分的演讲是来自德国的 Tobias Maurer，他是曾经来过台湾，也是算普教授的学生了哈。他在 PSMA 的诊断跟治疗方面有非常精辟的见解，所以请各位在稍事休息之后，准时1点40分来听我们这个 Tobias Maurer 的演讲，谢谢。
Hi, Toby. It's now
Hello.
1:37, so about 3 minutes from now. Okay.
Okay.
What time is it now in Germany?
It's early.
It's early, about 6?
6:30, 6:40.
6:30. Okay. 现在在德国是早上6点半哈，所以so are you awake already?
I hope so.
Okay. 那个趁现在我们还有一点时间跟大家稍微闲聊。Now I'm talking to the audience about you, about what your relationship with Taiwan, but that'll be in Chinese.
Okay.
他这个我就是叫 Toby 哈，他在18年前，他还是医学生的时候，他那个时候是德国慕尼黑科技大学的医学生，他又来台湾了。他来台湾做交换学生，那个时候他好像是医学，他们叫医学4年级还5年级，那他2年以后就毕业哈，医学系毕业。他那个时候来是来台大，来泌尿科，因为他本身是泌尿科医师哈，那他现在是 PSMA 的专家了，全球的专家哈。当然大部分专家都是合医，但是他是泌尿科医师哈，德国人。那他会Are you still learning Chinese or speaking Chinese?
我会说一点点。
Okay. How about your sons? I know your sons speak.
They speak Chinese better than me.
对啊，他有3个儿子哈。那这个因为妈妈是台湾人，他妈妈是台湾苗栗的人，那所以他们这个妈妈教小孩子这个中文，所以小孩子他们来过台湾很多次了啦，因为常常要回娘家哈，就回到苗栗去，就带着孩子来，所以跟台湾的关系很密切。他这个来台湾应该 So how many times have you been here in Taiwan? 10 or 8?
Whew. A lot.
A lot. I know a lot. I know it must be a lot. OK， 大概剩下1分钟哈，那就请大家先坐好哈。我们今天 PSMA 的题目非常的多，他是从泌尿科医师的观点来看 PSMA 哈 ，PSMA。OK， 那我们时间到，我们可以把后面的门关起来好吗？ Okay, now it's really our pleasure and honor to have Dr. Tobias Maurer. He's a German. We're glad to have him with us. Dr. Maurer is a urologist. He is among very few experts in the world who have been deeply involved in the research of PSMA PET for prostate cancer. It was back in 2002, as I just mentioned, when he was a medical student, he visited Taiwan, Department of Urology, National Taiwan University Hospital. I was the supervisor for him back then. So 18 years have passed. He's now a world famous expert, scholar, and now working in the clinic, the Martini Clinic of University of Hamburg, Eppendorf in Germany. And that is a center, the largest center in Germany that have over 2,000 radical prostatectomies a year. 2,000 radical prostatectomy a year. That is a very, very large number. So in the past few years, PSMA PET has become the most sensitive and most important imaging modality for prostate cancer in terms of many different clinical settings. I believe Dr. Maurer today will give us many more new information about PSMA PET. Now let's welcome Dr. Tobias Maurer.
Thank you, Professor Pu. This was really a nice, kind introduction, and I really enjoyed my stays in Taiwan and visiting the urology department. I also have to say really thank you. I'm honored to contribute here to the National Taiwan annual meeting of the Society of Nuclear Medicine. And well, I want to talk a little bit. I'm trying, I hope it works. You can see my screen now?
Okay, please.
Okay.
我们可以再调整一下那个荧幕，让 slide 的内容大一点吗 ？Okay.
Okay, so I want to talk to you about the PSMA PET, obviously imaging and therapy, and give you a little bit a perspective from a urologist point of view. You all know PSMA is the prostate-specific membrane antigen and shows overexpression 100, 1,000-fold sometimes in prostate cancer cells. On most prostate cancer cells, 95% of prostate cancer cells show this molecule. And there have been small ligands developed targeting the extracellular domain, and that can be used for imaging as well as therapy. So there are several tracers available actually for PSMA PET. The most widely used is gallium PSMA 11, developed in 2012 at the German Cancer Research Center in Heidelberg. And there are also newer tracers. You see that on the right side, which also show, also labeled with fluoride 18. And I want to attract your attention to two tracers that are not excreted in the urine, PSMA 1007 and radiohybrid PSMA 7. And those might be a little bit of advantage, at least when you concern the future, because they don't give you the urinary background, and therefore you can evaluate the local area after radical prostatectomy, for example, with a little bit more detail. And also fluor-18 is widely available, shows a longer half-life, and this makes it easier for distribution. Gallium-68 has 68 minutes, fluor-18 has 120 minutes, and so you can maybe produce it at a cyclotron where fluor-18 is produced, and then ship it or bring it to another institution. Fluor-18 compared to gallium-68 shows a little bit better image contrast as the positrons don't travel as much to the tissue until they reach the negative charged ion and give the signal for PET. The disadvantage with the new fluorine PET tracers is that they sometimes show increased unspecific accumulation into the ribs, for example, or inguinal lymph nodes. But what I want to talk about to you today is the indications where we as urologists could are using imaging in prostate cancer. And I picked now 4 clinical scenarios. Suspicion of cancer, so this patient has not yet the diagnosis of prostate cancer, and here of course it is about detection of lesions mainly within the prostate. Then staging of primary prostate cancer, I'll talk about that in a minute. Staging of recurrent prostate cancer, currently the main focus of PSMA PET imaging, and staging of metastatic disease. And the question is, should we use PSMA PET or should we consider to use it in those clinical scenarios? Do we really need it as urologists? And what do we need to consider? For once, of course, the availability of PSMA PET, the economical burden. Is it cost efficient to use this imaging? The evidence that we have in each clinical scenario and the expected impact on clinical management. And I split that up into how many patients would receive a change of management, so the percentage of patients, and how severe would the change of management be? Is it just a minor change or is it really a significant change of management? So about suspicion in prostate cancer, where it is about detection of lesions. Here we have only really few data and retrospective studies that compare the standard imaging, if you want to say so, multiparametric MRI with PSMA PET-CT or PET-MRI. And also the results are diverging, I have to say. When you talk about fusion biopsy, so you see something on imaging and want to do a exact targeted biopsy and want to do a fusion biopsy, then obviously PET MRI is better than PET CT because you don't have the registration issues. On the other hand, PET MRI is really not available at a lot of institutions, and it's an expensive, of course, examination. And we have level 1 evidence for multiparametric MRI in this setting. We have the PROMISE study, the precision trial, that show that multiparametric is in fact performing pretty good. We also have, albeit a retrospective analysis that show that the outcomes of patients with a negative multiparametric MRI, so an unsuspicious MRI, is not so bad. We have cancer-specific free survival at 4 years, 95% or 96% in biopsy naive or patients with prior biopsy. So, of course, you can gain additional information. And you see here on the left side the T2 sequence of multiparametric MRI. You see the diffusion-weighted imaging on the bottom. You see the gallium PSMA on the upper right side fusion image. And you see the dynamic contrast enhanced image, basically all depicting the same lesion. And we just had a small publication this year with 57 patients who received a PSMA PET MRI prior to biopsy. And what you can see from this chart is that the aggressive cancers, they are seen in both imaging modalities, on PSMA PET as well as multiparametric MRI. So what my personal view, want to say about PSMA PET for detection of prostate cancer, even if it would be superior, most significant tumors might be detected by multiparametric MRI, follow-up or repeated biopsy. So I think the evidence is very low. The percentage of patients that will profit is probably negligible, and also the change of management is probably negligible. When we look at the EAU guidelines, it's a clear, strong level 1A recommendation to perform multiparametric MRI before prostate biopsy in naive patients and in patients with prior negative biopsy. So we do have a really good imaging for detection of suspected prostate cancer. What about staging of primary prostate cancer? And we talk here, basically I talk here only about lymph node staging, but of course it's also true for local staging and metastatic screening. We have here a rapidly increasing number, mainly retrospective studies and reviews, reporting increased detection rates for local lymph node or metastatic staging. The most evidence here is for lymph node staging, and also there are several studies with histological confirmation. And there's just one example on the bottom that you see clearly positive lymph nodes, also histologically proven. And since this year, Michael Hoffman published the pro-PSMA study in Lancet. This was the first prospective evidence that we have now of superior accuracy of PSMA PET compared to conventional imaging, standard imaging, CT, and bone scan. In this study, 302 patients were randomized to receive either first CT and bone scan or first PSMA PET, and then they had a crossover imaging unless you see already metastatic disease. The hard criteria, then reference standard, was histopathology. In those patients, I have to say, not a lot of patients got surgery. I think 86 patients, if I recall correctly, but also sclerotic changes due to therapy in the bone. That was also a hard criteria. And there were several soft criteria for evaluating or as a standard of truth. When we now look for the lymph node detection, and we see the specificity, blue is conventional imaging, red is PSMA PET. The specificity for both examinations was very high. The sensitivity, however, was a lot greater for PSMA PET because they picked up smaller lesions that were not suspicious on conventional imaging, and that also then turned out to increase the accuracy of PSMA PET compared to CT and bone scan. And another finding that I find very interesting is that with PSMA PET, you hardly have equivocal findings. Here of 148 patients, only 2 patients had equivocal findings. In the conventional imaging group, this was larger, 9 patients out of 152 patients. So the primary outcome showed that PSMA PET had a 27% greater accuracy than conventional imaging for detecting lymph node metastasis or metastatic disease. When we look at the secondary outcomes, change of management, again here PSMA PET superior to conventional imaging, 28% versus 15%. The second line imaging, so the crossover imaging, also here there was a change of management, a significant change of management with PSMA PET seen. Equivocal studies, I talked about that on the last slide, less seen with PSMA PET, correct staging, and the radiation dose also, since they used a low dose CT together with a PET examination, was lower, significantly lower than CT, diagnostic CT, and bone scan. Can we also get diagnostic prognostic information from PSMA PET? And here actually there's really no data out, and we just submitted an article to a journal, and we evaluated patients who underwent surgery for intermediate to high risk prostate cancer and had a PSMA PET before, and all those patients who received neoadjuvant therapy or inductive therapy were excluded. So we could analyze 230 patients, and we analyzed biochemical free survival and therapy-free survival and correlated that to the findings of preoperative PSMA PET. The evaluation of PSMA PET followed the PROMISE criteria that were proposed, and we actually looked at lymph node status. So if we have only one lymph node, which was called molecular imaging N1 positive, or if we had 2 or more lymph node pelvic lymph nodes. And when we look now at the biochemical free survival of those patients, we see a clear distribution. Patients who had a just histologically positive lymph node disease after extended pelvic lymph node dissection, but were not seen on PSMA PET, that's the yellow line, showed a better biochemical free survival than patients who had also suspicious lymph nodes on PSMA PET that were proven histologically. The same also holds true for therapy-free survival. So with these results, you can debate of those patients when you see preoperatively positive lymph nodes, maybe these are candidates for inductive therapy, for multimodal concepts. At least you can tell the patients that they are at higher risk of receiving a biochemical failure and or additional treatments. So for primary staging, my personal view is we have now the first prospective evidence of superiority of PSMA PET compared to standard imaging CT and bone scan from the pro-PSMA study. But there's still no prospective evidence of improved outcomes of PSMA, and say yet, because I think that is to come. We have now different, I split up the clinical scenario for primary local staging. I didn't talk about that now, but I think here still the evidence is low. And I also think only a few patients would have a change of management, because most patients would undergo a whole gland treatment in intermediate to high risk patients. For example, radical prostatectomy or radiation would involve the whole gland, and the severity of change, if there is a change for focal therapy or maybe boost radiation, would, I think, in my eyes, be minor. For lymph node staging, I think we now have good evidence to say it's better than conventional imaging. I also assume that not so many patients would receive a change of management, especially patients, high-risk patients. But then the severity of change could be minor to major when you think now about a different therapy line, if you think about neoadjuvant treatment. So I think it has value there. For primary metastatic staging, the evidence is intermediate in my eyes. We have low percentage of patients that would receive a change. But then this change, if you detect now metastatic disease on PSMA PET, I think in the end would be major. The EAU guideline perspective is that, yeah, PSMA PET is more sensitive for detection lymph node and bone metastasis than standard imaging. The clinical benefit to detect those metastases earlier is currently unknown. Also, the prognosis and the ideal management. So we do need to have studies, prospective studies. The best would be randomized controlled trials to really evaluate the potential of PSMA PET in the setting. But I think this is to come. Staging of recurrent prostate cancer. And here we have a great number already, mainly retrospective studies and reviews, but also some prospective studies emerging, like the one from Fender in the middle bottom, where you see at low PSA values, you can not only detect local recurrent tumor, but also pelvic lymph nodes and even extra pelvic disease. Histological confirmation only in a minority of patients. That's a drawback in these settings. So this is actually how we treated prostate cancer biochemical failure previously. We don't really see where the street is, where we're going, but we assume we know the way. These are 3 patients with a PSA below 1 after radical prostatectomy, but a biochemical failure. It would be much nicer to have clear view, or to have a PSMA PET which shows you now 3 different patients, actually. One with a local recurrence that might be treated with local radiation, one with a atypically located lymph node where it is currently unknown what the best treatment would be for this patient, and a patient with a bone metastasis, which obviously also needs a different treatment approach. We see, and there are some studies, that PSMA PET influences the clinical management of recurrent prostate cancer. There are emerging analysis showing that the change is probably most pronounced in early biochemical failure. There are no prospective analysis on the oncological outcome yet. Yes, and on the bottom I show you just a slide from Roche. It's a prospective Australian cohort where they looked at the change of management in biochemical failure. And you see, even at low PSA values, 60% of patients had a change of management. And the other analysis by Han in European Urology 2018 showed a change of management in 55% of patients after PSMA PET. I just want to highlight this with one example. It's a 63-year-old patient with a biochemical recurrent prostate cancer, early biochemical recurrent. He had initially a high-risk cancer, Gleason score 9, locally advanced, clear margins, has no hormonal treatment, and the proposed management prior to a PSMA PET would be salvage radiation to prostatic fossa. He had no lymph node involvement. This patient underwent PSMA PET, and that showed a atypically located lymph node again. And now we have a change of management after PSMA PET. We can either perform salvage radiation to the fossa and to the lymph drainage plus minus the fossa, or we can do perform a salvage lymph node dissection, which was done in this patient, showing 1 positive lymph node out of 18 additional lymph nodes removed, and the PSA dropped to 0 basically. Just about PSMA theranostics, when you do those kind of procedures, you might want, it's not always so easy to find those lymph nodes. You might want to have something to identify those lymph nodes intraoperatively, and you can do so by using technetium labeled PSMA ligands that the patients get injected prior to surgery, and then intraoperatively you can use a gamma probe to detect those small lymph nodes and ensure successful removal. And I have now a short video, I hope this works, of a young patient showing a PSMA PET positive lymph nodes, early biochemical recurrence. So this lymph node could be clearly detected intraoperatively, but there was also an additional small lesion which was hardly seen on pre-op imaging. And this also proved to be metastatic lymph node, a small one. So you can use actually PSMA radio-guided surgery also for local recurrence. And this is a patient who had radical prostatectomy, had local salvage radiation, and again, only showed a local recurrence. And we just published this one in European Urology, 40 patients that underwent then also salvage surgery and most patients experienced a quite dramatic drop of PSMA PET. Of course, long-term follow-up and long-term oncological results are still unknown for those patients. So I want to summarize: for recurrent prostate cancer, we have superior detection rates by PSMA PET, and this enables also PSMA targeted therapies. However, what we need is more detailed analysis, especially in biochemical recurrence after radical prostatectomy and in biochemical recurrence after radiation. Also in patients with or without use of hormonal therapy. And we actually also have here different clinical scenarios. And I think the one patient that profits most is the one with an early biochemical recurrence after radical prostatectomy and no ADT performed. The evidence here, I think, is intermediate, percentage of patients low to significant, depending on the pre-op risk factors, and the severity of change might be minor, but also could be major when you do now a targeted approach, for example. The others, early biochemical recurrence after radiation, we still have less, not a lot of data here. Probably a few patients only would have a change of management, because most patients who receive radiation first had a reason for that and probably are not surgical candidates. Then early biochemical recurrence and ADT already administered. I think here also we have low evidence, we have few patients and probably only a minor change also with higher PSA values. What do the EAU guidelines tell us here? They say when we have persistent PSA after radical prostatectomy, we should exclude metastatic disease by PSMA PET. If we have recurrence after radical prostatectomy, so after a PSA of 0, rising PSA, we can also perform PSMA PET if the results would influence subsequent treatment decisions. The strength of those recommendations is, however, weak. We don't have the data yet. After radical prostatectomy, we should use PSMA PET-CT if we think about curative salvage treatment, because we need to rule out metastatic disease, and this is a strong recommendation. So the last one is staging of metastatic prostate cancer, and here we want to evaluate the extent of the disease and the response assessment. There are preliminary results from a few and retrospective studies, often in combination with lutetium PSMA radioligand therapy, but there are also novel measurements of tumor volume that are evaluated. And here you just see examples prior and after docetaxel treatment, and you see clearly that this patient is responding to treatment. PSMA radioligand therapy, this is enabled actually when you do, of course, a PSMA PET in those patients with castration-resistant metastatic prostate cancer. And there are increasing number of retrospective case series that show PSA declines over 50% in almost half of those patients, rare grade 3 and 4 toxicities. And this is just an example of one of the first patients treated in Munich, and you see the disease after lutetium PSMA practically vanished. The PSA almost 800 was 0 after 4 injections of PSMA PET, PSMA lutetium. There's also now prospective evidence out. Again, Michael Hoffman from Australia presented at ASCO this year the therapy trial. This was a trial where patients with castration resistant prostate cancer after docetaxel, which was suitable for second-line chemotherapy with cabitaxel, received PSMA PET and FDG PET to rule out discordant disease. And those patients were randomized 1-to-1 to receive either lutetium PSMA radioligand therapy or cabitaxel. The primary endpoint was PSA response. And here the first data and the primary endpoint was reached. In those men, you see 66% had a PSA response, over 50% in the lutetium radioligand arm versus 37%. The secondary endpoint is not mature yet, but also you see the progression-free survival also favors lutetium PSMA, and relatively fewer grade 3 and 4 adverse events were seen with lutetium PSMA. So I think this would be another interesting treatment option for those end-stage patients. There's also the VISION trial currently still ongoing, but we eagerly await the results. Over 800 patients enrolled after taxane chemotherapy and at least ABI or ENSA, and they are randomized 2-to-1 to receive either lutetium PSMA and best standard of care versus best standard of care. So to conclude this section, PSMA PET, I think, can serve here as a one-stop shop examination and provides us with additional information about molecular targeted therapies if we want so. We still have insufficient information, however, concerning response evaluation using PSMA PET. And actually, we have low evidence here in this area, but I think this one is emerging soon. Also, the EAU guidelines just state a short sentence that the use of PSMA PET scans for CRPC is unclear, the benefit, and they think and strengthen the point that the most beneficial probably are the early biochemical recurrent prostate cancer patients. So to conclude my talk, PSMA PET shows superior detection rates for prostate cancer lesions. It has a great impact on imaging. As we all know, most useful probably staging of early biochemical recurrence without hormonal therapy. And in primary high-risk prostate cancer patients, I think we will see that. And there are diagnostic approaches with promising potential, mainly PSMA radioligand therapy, and maybe in a few patients also PSMA radio-guided surgery. So that was a long talk. I hope you enjoyed it, and I thank you for your attention.
Dr. Maurer, because of the time, we are about 3 minutes late. So maybe just one question from the floor. Any questions about PSMA PET? I believe Dr. Maurer knows that in Taiwan there is only 2 centers that can that is able to perform PSMA PET imaging, and right now there is no theranostic in Taiwan. So are there any members in this association that would like to know why there are so few centers that can do the PSMA PET? Or the president, Yan, can you give us a comment why there is only 2 centers that can do this? In or Chinese 就可以。
Hi, Tobias. Nice to meet you again. Yeah. 我想为什么台湾还没有这么多center 可以用？当然 ，first of all, it's because of gallium-68 generator is not very available in Taiwan yet, and the price is expensive. And also, I think we are now have F18 PSMA. So I think in the future, if PSMA can get a clinical trial approval from our TFDA, I think we can provide the F18 PSMA to other hospital, and I think they can use this PET imaging for prostate cancer for the detection. Yeah.
Thank you. We thank President Yan. Because of COVID-19 pandemic, Dr. Maurer is not able to come to the meeting in person, but I believe in maybe next year or the year after the next, he will be happy to come back to Taiwan. I mean, come back, it's not come to Taiwan. So, so we sincerely hope he and his family stay safe and be healthy during the next several months to come during the pandemic. So thank you again, Toby.
Okay,
Thank
thank you.
you.
我们谢谢他，谢谢。
Hope to see you.
那我们要接下来下一个节目，好，谢谢大家。